All right. Dan Lorenz, welcome to the Informed Performance Podcast.
Great to be here, Dylan. Thanks for having me.
All right. So I'm really excited about today just because I think blood flow restriction has been a topic and a concept that has kind of rode a wave a bit of like ebbing and flowing. I just see it kind of like coming up a lot, whether it's through social media outlets, whether it's through research papers, and then I see it kind of maybe dying down for another couple months, and then it resurfaces and just keeps on coming up and down. And so recently, when I have seen a lot more people kind of discussing it and, you know, chatting about it, I wanted to kind of get somebody like yourself on who's familiar with the implementations, both from a research side of things as well as practically. But before we go too far into the weeds on blood flow restriction, Dan, if you just want to take the floor, introduce yourself to some people who maybe haven't heard you yet, and we'll just go from there.
Sure. I'm originally from the Chicagoland area. I have a Bachelor of Science in Health Sciences with an emphasis in athletic training from Grand Valley State University in Michigan. That's in 1999. Master's in PT from Grand Valley State in 2001. I got my DPT at the University of St. Augustine, a transitional one after that. And then I did this Duke University Sports Physical Therapy Fellowship from 2004 to 2005. I was a physical therapist and athletic trainer for the Kansas City Chiefs for a couple years. I had my own private practice for about 7, built it to about 3 clinics here in the Kansas City area. And then now I'm the Director of Sports Medicine at Lawrence Memorial Hospital and OrthoKS in Lawrence, Kansas. Also was the founder and co-chair of the Performance Enhancement Special Interest Group for the former sports section, but now the American Academy of Sports PT. So do a lot of teaching on the side, and I've been doing that for a long time. So I suppose that's about as quickly as I can be on a bio to not spend too much time on it.
No, I love it. Especially having a career like yours, there's probably many bullet points to either add or skip over, those sorts of things. So I appreciate it. But what was the impetus for sort of writing the paper that you guys had wrote back in 2021 on blood flow restriction? What kind of drove that?
One of my co-authors, Terry Grindstaff, who was on staff at Creighton University, it was a hot topic, and they often do these current clinical concepts papers in Journal of Athletic Training, and at the time, it was certainly a very hot topic. People were learning more about it. It was being used more often. It was popularized in the media. People saw it a lot on TV and on ESPN and things like that. So naturally, that led to some discussion. And like anything else in our field, I think a lot of people kind of went all in on using it. And so often, whether pick any modality in our field or any method of treatment, oftentimes we step on the gas and we do it without knowing how to do it. Is there any research behind this? Is this all theory? Is there actually some sound science, etc.? So I think that was really the impetus for writing that paper.
Right on. Yeah, and it's always interesting to have that kind of the early adopter phase where, you take a couple risks when it comes to those sorts of implementations of, if you can appreciate some of the basic science behind it, if there is any at the time, and then implement it. But so often I feel that the early adopting crowd tends to be a similar crowd that finds a new trick and implements it for a lot of different areas that, whether or not there's rationale for that area is kind of up to the evidence to dictate. But when we're looking into some of maybe the evidence on basic science, what are some of the proposed mechanisms of effectiveness when it comes to blood flow restriction, and maybe just giving a broad definition of what blood flow restriction is before we dive into that?
Sure. So blood flow restriction training essentially is restriction of blood flow. It's not cutting off blood flow. That's oftentimes misstated or misnomer. And the idea with that is that you can train in a low load environment for people that can't tolerate loads or are inappropriate for loading, and get similar benefits as you would with traditional strength training methods. So for example, somebody that's got maybe advanced knee arthritis, or maybe they've had a cartilage restoration procedure where typical compression and shear forces with a leg press or a squat might be very irritable. Well, what blood flow restriction training allows you to do in these cases would be to train with a cuff on that is inflated to almost full arterial occlusion, but not quite. But you could do it at a much lower load and get similar benefits that you would get with normal training. Normal training, as you train with with heavy loads, there's growth hormone, there's other metabolic processes that happen with normal training, and the idea is that we can still get those processes in a lower load environment. So as far as mechanisms go, I think we're still kind of figuring some of those out. As I mentioned before, there are a lot of hormonal changes: vascular endothelial growth factor, myogenic stem cells. Let's see here, the mTORC1 protein pathway. And these are all really complicated biochemical processes, but those pathways are stimulated with normal higher load training. But the good news is that they're also stimulated in a low load environment, right? So that's what I said. That's the great thing about this, is that you can get the strength and hypertrophy with lower loads. In addition, because of the effort required in the low load environment, a lot of times you're getting to failure or darn close to failure. And because of that, you get activation of the high threshold motor units, which, as those are more recruited, there's an endocrine response, there's accumulation of metabolites, and there's this cascade of biochemical things that happen after that lead to muscle growth and hypertrophy, or muscle hypertrophy and strength. So that seems to be where the rubber meets the road with BFR, but certainly there's analgesic effects from it and other benefits from it as well.
The kind of metabolite route and different pathway route is always very interesting. Namely because there's many different new names and pathways that people hear about and those sorts of things, and as well as that kind of just sort of stimulation of whether it's growth factor or anything else. Anecdotally, I've heard from some people where, let's say you slap on a BFR cuff, when they say, all right, we're going to try and bring this cuff up as high as possible. There are a couple different concerns or reasons maybe why that is, but one of them I've heard consistently is we're going to try and occlude as much muscle mass as possible so that we can then try and create a larger response of those sorts of growth factors, whether they be metabolites or the actual growth factors themselves. Does that seem to be accurate, where we can try and more or less maximize that stimulation or that response by occluding more muscle mass?
Well, you're not occluding, maybe I misunderstood your statement. You're not really occluding muscle mass. You're occluding, you're restricting arterial flow, basically. So are you asking is the question, is going higher pressure more beneficial?
No, sorry, I'll rephrase it. Rather than saying, hey, let's say we have an example of somebody wanted to do calf raises, right, with BFR, or some sort of lower limb exercise. If we were to occlude higher up towards, closer to the hip joint itself, I've heard from different people that it may stimulate a larger metabolic response because the blood flow that's occluding is supplying greater amounts of muscle mass.
Yeah, I think it's because the vessels are larger in the proximal portion. The benefits at this point definitely appear to be distal. There was actually a review article that came out end of 2023 that looked at proximal benefits, and there's super low quality evidence that there's any proximal. So it does seem at this point that the benefits are distal. But that being said, you don't want to put a blood pressure, a BFR cuff on the proximal calf, or just distal to the knee to train the calf. You got a pretty important nerve right there behind the fibular head that you don't want to be compressing. So, that's that superficial. So, I understand your question now. Sorry, I misunderstood it. But yeah, obviously the femoral artery is pretty robust in the proximal portion. So typically being occluded in the proximal portion of the muscle, when speaking about the calf, is the way to go.
Understood. Yeah, it's definitely helpful to kind of conceptualize. When we think about BFR as a whole, I think a lot of times people will immediately jump to the rationale of it can be effective in a post-op sense, right? Your load compromise, whether it be, like you had said before, whether it's a chondral injury or surgery, or ACL surgery, or typical for using BFR. Is there any merit to kind of maybe comparing and contrasting the idea of using, obviously, BFR in a known sense that we've talked about with ACLs or chondral injuries versus something along the lines of a chronic pathology like a tendon issue? is there merit for using it on more of that chronic side, or do you think that it's a little bit more on just load compensation?
I think we're learning more about that. I did a talk in 2017 in Las Vegas at the Team Concept Conference, and I had to talk about blood flow restriction training and tendinopathies. And I asked at the time, I reached out to Jill Cook and Karin Silbernagel, who in my estimation, are two of the better tendon experts in the world, frankly. And at the time, they had both said that they didn't really see any utility for it. There's been a couple studies since then that have shown some benefit of BFR in cases of tendinopathy, some positive changes to the tendon. But I would say that it's still, for me, it's not the first line of defense. Tendons love tension and they love load. And there's not a lot of tension, and obviously the loads are pretty low. But is there an analgesic effect to it? Possibly. So, like I said, I think there's a couple studies on the Achilles. Is that because of the BFR? Is it because of just the loading in general? Hard to say. But right now, for me, it's not the first choice. Now, chronic knee pain from arthritis, that's a different story. I think there's probably some benefit there, especially in cases of atrophy or disuse atrophy or from pain. But tendinopathies, I think we're still not sure yet.
And then what about this concept of, training to failure? I think there have been a couple papers that I've seen come out recently, or at least within the last couple of years, that have kind of done this sort of compare and contrast of using low load BFR training to failure and then standard training without BFR to failure. And I feel like sometimes people will say, oh, okay, well, all you have to do is train to failure. Is that something that you find accurate? Is there still reason to implement BFR if we have evidence showing that, maybe all we need to do are those same effects are mediated by just training to failure?
There's been a number of papers in the last few years that have shown, the muscle really doesn't care what the load is as long as you go to failure, right? So there's been a few that have shown that with or without BFR, if you train to failure, you're going to realize gains from that. So I think the idea of failure is that that you've maxed out what the muscle can give you, basically, right? Like all high threshold motor units are on deck, so to speak, right? So I think that there is and that's why I tell people all the time, if you're not comfortable with this, or if you're an administrator, or if you're working at a university setting and they won't do it for whatever reason, you can still do what we've always done. You don't have to do this. You could just go, loads to failure, whatever those loads might be.
Yeah. And speaking of kind of some of those concerns or what maybe an administration may be, apprehensive or hesitant about, what are some things that we can do on a safety side to either mitigate any of those concerns or maybe just understand a little bit more about the process of blood flow restriction to the point where we can be more confident in the fact that there probably won't be as many adverse events as many people might assume?
Well, like anything else, whatever modality you use or whatever treatment technique you use, whether it's instrument-assisted stuff or, cupping or needling, you don't just, dive in without any indication of who do you do this on, what's the relative or absolute contraindications, what are the indications. You need to start there. Start with the background of it. How is it applied? What patient populations are the most appropriate? To me, that's not different from any other one, like I said. Where there tends to be some fear mongering, I think, is whether or not you need to be certified. I think that's something we have to be careful with as a profession because how many things do you use that don't have a certification, right? Do we really want to go down the road of you got to be certified to use a foam pad or a let's just say a BOSU, or do you have to be certified to use a treadmill? Come on, right? So you don't need certification, but like anything else, if you're going to use this stuff, you should take a course. There's a ton of them out there. There's a ton of really smart people that have done things. Do your reading, do your background, talk to people that are using it. You need to find out the different nuances between the cuffs and the pluses and minuses. There's different price points. That's what I said. A lot of this is just intuitive. You got to do your homework before you dive in. But do you need initially when this kind of came out, there was some, you have to have an FDA approved product. Well, there's no approved product for the FDA for this. There's a lot that are listed with the FDA, but it's kind of an off-label use to use these for exercise. So I think that's probably the best summary I can give you in this. I mean, like I said, it's on you as a clinician to make sure that you're educated on the subject.
Most definitely. Maybe going into some of the kind of methods and implementations behind BFR itself. There have been some things out there where it comes to whether ischemic preconditioning, or whether it's passive BFR or BFR with some kind of neuromuscular stimulation or those sorts of things. Can you maybe just touch on some of those options? How clinicians may be able to best implement them, if they're effective or not. Maybe just give a little bit of a background on some of those areas.
So I'll start with the BFR and NMES. There have been several studies showing that BFR is a great adjunct to doing NMES after knee surgery, for example. So if you haven't done it, it's something worth considering. In regards to ischemic preconditioning, I say that that's kind of a first cousin of BFR. Most of the ischemic preconditioning papers, interestingly, a lot of it was in like cardiac research. If you go down that rabbit hole, going back to the 80s, 1986, I think, is the first paper on it in cardiac rehab. And really what it is that it's more passive. It's full occlusion for about 5 minutes. You're pretty much not doing much. And then you deflate for about 3 to 5 minutes, depending what paper you read or whose opinion you're following. And then usually you do that for about 3 cycles or so. And essentially what they thought in the cardiac literature is that you're essentially, and the way, I'm a simple guy. I try and dial down what everything means to the for simpletons, right? And to me, it seems like you're teaching the heart to do more with less. So that was the idea behind that, and there's certainly metabolic benefits of it. There's been some studies that have shown increase in microvasculature and things like that through the ischemic preconditioning. And then when you talk about recovery, and that's where I think that's probably we're on the horizon to learn more about it, where there's going to be more. I know for a fact a lot of professional sports teams are using it. There was a recent paper was it beginning of 2024, end of 2023. Stephen Patterson's group, I think it was in Biology of Sport, maybe it was the journal, and they did a review article on recovery in BFR, and the problem is that is it active versus passive recovery? A lot of the protocols are fatiguing, whereas sports aren't necessarily fatiguing. The implementation and the parameters are all over the map, so therefore it makes it really, really hard to synthesize, does this really work? I know for most people that are doing this in a recovery standpoint, I have a feeling that most of it is kind of we had an intense game. Now we're doing BFR as a recovery. You can do light exercise that's a little more intense basically. If you look at the recovery studies, a lot of them, the ones that show a positive effect, where they do like ischemic preconditioning, it seems that the effect is not acute, that it's 24 to 48 hours later. So for example, if you finish a game on Monday and you do ischemic preconditioning after the game for recovery, when they do like tests shortly after that, there's not a lot of benefit yet. It's 24 to 48 hours down the road. So a few have shown that, a couple haven't. So I really do think we're kind of at the beginning of learning more about the utility of blood flow restriction training, as well as ischemic preconditioning for recovery.
And obviously there seems to be, like you mentioned, some variability in terms of how this is implemented. Maybe from your kind of practitioner's hat, where do you see, let's say somebody, a lot of our listeners tend to be either very interested or working in some sort of level of team sport and pro sport. Where would you tend to see that be most effective from kind of your, I guess we call it expert opinion side of things? Where would this be something where it's maybe cardiovascular based exercise? Is this passive? Is this with NMES, even if there isn't an injury? Where does your head go as like as something that makes the most sense in your head as a recovery based modality?
Let me start with the upper body. I know a lot of folks working in baseball circles that they don't necessarily like the BFR for exercise, like for the cuff and stuff, but they do like it, like they'll put the ischemic preconditioning on, and like pitchers, for example, will just say how great the arm feels after the fact. Now, whether or not that's placebo, whether or not they feel like they got a pump or a flush, I don't know. But there does seem to be a benefit there. I think it's a lot of athletes will use like hot tubs or cold tubs or contrast bath to quote unquote get their legs back. I think that IPC is a probably has maybe a little more substance behind it from a recovery standpoint due to the full restriction, or the full occlusion, and then full occlusion, open up. There's some benefits there with increase in cellular swelling and kind of open up those channels. So there's probably some benefit there. I think a lot of people, when they talk about recovery, some of the best things to do for recovery after an intense match or a game is to do some light exercise to flush the system, basically. So I think BFR is a way to kind of enhance that, and that's whether it's on an exercise bike or whether it's just walking or maybe not everybody's favorite, but like on the elliptical or something. So or even just body weight exercise. It's just an enhancement of that. So those are probably where that's probably where most of the utility is. But to be frank, I'm not in that daily training room environment where I'd be using it every day. A lot of this is from extrapolating from the literature what it's saying, and then from talking to people that are in it every day and how they're using it.
It makes a lot of sense. Do you think that when we think about ischemic preconditioning, knowing that it's more or less full occlusion, does the intensity of the limb occlusion pressure, the LOP, actually make a difference when it comes to certain implements? Maybe we call it upper extremity and lower extremity, or whether there's a specific effect that you're trying to get from BFR. Does the limb occlusion pressure itself matter, or is BFR just kind of a BFR stimulus regardless?
Okay, I want to make sure we don't conflate IPC and BFR. So IPC is 100% occlusion. It's passive. You're not exercising with it. BFR, what we know to date is that if you can tolerate a higher pressure, you should do it. But if you can't, I have plenty of patients, like I have two currently, that are nauseous at 80, but they're fine at 70% limb occlusion pressure. So if you can train there, you should. But there are many papers that have shown that you could go lower intensities, lower pressures, and get similar benefit. So a lot of this depends on who's in front of you, what they can tolerate.
And then from an upper and lower extremity perspective, are there general guidelines that people tend to follow, that people try to adhere to when it comes to limb occlusion pressures, or is it pretty similar? Okay. Yeah,
so for the lower body, ideally you shoot for about 80% limb occlusion pressure or arterial occlusion pressure, depending on what article you read. And then for the upper body, it's about 50% limb occlusion pressure. And again, same thing, if they can't tolerate as much, you can certainly lower it. But yeah, just because the limb is smaller, the muscle mass is smaller, the vessels are smaller, you don't need as much pressure.
I think commonly the individuals that maybe you take a coursework or you take a course or you go through some sort of certification process, the common rep scheme that you kind of hear from most people is 30, 15, 15, 15, right? 4 sets total. Is there a reason behind that specific rep scheme? Is there something behind that makes it more effective than something else? How do you maybe implement BFR in your practice when it comes to the total amount of volume that you're using with the patients that you have?
Usually the total volume is anywhere from 75 to 90 reps per exercise. The idea behind the 30 reps the first set is, we have our type 1 and type 2 fibers, right? And our type 1 fibers are, they rely on oxygen, they rely on that blood flow, right? And the idea of doing the higher reps that first set is that we're effectively trying to, quote unquote, tap out the type 1 fibers so we can really get to those type 2 high threshold motor unit fibers. So if we do that higher rep the first set, you're kind of fatiguing out those type 1 fibers. And then ideally in those last 2 or 3 sets of 15 or so, you're really getting to failure or darn close to failure on that final set. I tend to try and push towards failure on the final set just so I know we've got their best essentially. But that's where you have to make sure, do you have the right pressure, do you have the right load? Because if somebody's approaching like 20, 25 reps and they still got more in the tank, one of those two variables has to change.
Yeah, I think the idea of anchoring is always effective when you can control for
Yes.
certain variables. So
Yeah, I mean, if you get somebody in the final set that fails at 13, 14, 17, I think you're right in the wheelhouse of the right amount of a right load for that person.
got it. Now, looking back, obviously the paper that you wrote was back in 2021. Knowing the evidence that you guys have or that you've kind of combed through now, are there any topics, or is there anything about that paper now that you would have changed, that you would have added to, that you would have subtracted? What's different between now and 2021 when it comes to the BFR literature?
That question, I reached out to a couple guys that I wrote it with, and I just said, hey, in your estimation, is there anything that's really changed? Because in mine, there hasn't. And there's been some more stuff on tendons. There's been more stuff on bone. They've certainly shown, there was a feasibility study where they did this on people with MS. So there was one with Colles fracture. There was some good benefits. So I can't say a lot of it's changed yet, or anything that's worth saying substantively that you need to change from that paper. I think if you still follow those guidelines, you're still going to be in good shape. I think down the road, we'll probably know a little bit more about the utility and recovery. We'll know a little bit more about this in tendinopathies. We'll know probably a little bit more about it, maybe on the mechanisms, exactly what's happening. I think we have a feeling what's happening, or we trended towards those high threshold motor units and things. But yeah, I just, no, I think you're good to go if you still follow that stuff from 2021. I think we've just had more papers to affirm that, hey, it's good for bone, hey, it's good for muscle, hypertrophy and strength in a lower load environment.
Got it. When we're thinking about the implements of BFR, I think is similar to what you're saying. Like the principles are staying the same. It's just kind of how we're able to then look into okay, what else can this also do? And I think a common theme that I've heard recently is the implementation of cardiovascular exercise. So whether that's on a bike, whether that's walking, like we had mentioned even before, it could even be an elliptical. But is there anything specific about the implement with BFR and cardiovascular exercise that makes it different from lower load resistance, right? Are there limb occlusion pressures that are different? Is there timing, schemes that are different? Is there anything else, or are we still kind of looking at a pretty similar method of implementing BFR when it comes to cardiovascular training?
I think the pressures are still largely the same, like for the legs. I think the difference is you maybe can go a little bit longer because you're not lifting, right? Where they're trying to get to that quote unquote failure. Like I said before with ischemic preconditioning, I think there's probably a quote-unquote flush of the system, when you release the cuff. But also, again, you're asking the muscle to do more and the system to do more with less, right? You're having to become more efficient. There's an increase, like I said, in that microvascular blood flow. There's an increase in nitric oxide, those types of things. You're basing it kind of on that heart rate reserve, and you're kind of around that 50% or so if you're doing that calculation. I mean, I tend to talk to people, in the clinic more about, kind of the effort that they're putting forth. You try and really get people to understand that RPE scale. So, I think from a cardio, like if you're getting somebody on an exercise bike, you probably can go up to 20 minutes. Really, it just comes down to if patients need a break or if they're uncomfortable. So you might go 5 minutes, deflate a minute, 5 more minutes, deflate a minute, just to give them a break. If they can tolerate 10, go 10, and then deflate for a couple, finish up for 10 more. That's probably the difference, I think, with that versus like the muscular piece. But I think it's really just more increasing that aerobic capacity because you're asking, like I said, for it to do more with less.
Totally. And it's interesting. I'd heard another professional in the space kind of talk about the idea that, it's interesting with aerobic training just because aerobic capacity is determined by a whole host of different variables, right? You have central, right. You have peripheral, you have all those sorts of adaptations. And so you kind of have, more choices on the menu to select from on how you improve, somebody's cardiovascular, endurance or metabolic conditioning. And so I think using something like that it's an interesting implementation of, it's a slice of the pie that you can, augment, but it may not be everything.
Right.
Wrapping things up a little bit, Dan, where do you think that people could potentially, I guess I use the words like go wrong, using BFR, whether that's, we can already discuss safety considerations, but maybe it's just kind of clinical reasoning. Like what areas do you think you've seen people or heard about things that maybe people aren't using it as effectively or too much or things like that?
Lots of ways to go here, so I'll just kind of run through a list of some things. So one, if the cuff isn't appropriate, like if the pressure's not right, if you're leaving, I remember I was somebody was saying, I'm on the, they're lifting for like 40 minutes with it on, and I heard somebody say that once, like, well, pressure's probably not there at all, or the loads are way too low. Like you're really, if you're really using this right, you should be every exercise, probably around 5 to 10 minutes or so, and then you're going to need a break, kind of a thing. So that's one. The loads, like I said, if they're too low, if you're not adjusting loads, like, if you do this, if you just slap somebody on BFR with their 5-pound cuff weight every time, probably not doing it quite right. Not having, again, the problem is with this too is price points. Like a lot of people want to do this stuff on limited budgets, so of course, like anything else, there's price points and making sure that you have an appropriate pressure to train at. So that's a piece of it too. I think if you're only using BFR, the idea, I want to say, I hope I don't misquote the person. I think this is the person that said it, but Kyle Kimbrough is a guy in this space that thinks says the purpose of BFR is to not use BFR. If I want to give appropriate credit, if it's not him, sorry. If it is him, I just want to make sure I did give him credit for saying it. But I think it's nicely stated that, this is supposed to be a complement. It's supposed to be an adjunct. It's not supposed to be something you only do. I say that, but I have one, I've even put this on, I posted this on X. She's like with a crown jewel BFR patient of mine that I have current patients. She's had, multiple cartilage restoration procedures. She's had a tibiotubercle transfer. She's had MPFL reconstruction. Her knee is a mess. She cannot tolerate the typical loading. And we do BFR twice a week, 3 exercises each. And I test her on that kinetic machine. And to see her numbers and her pain improve, it's truly been remarkable. So if it's done right, it can really do great for people. But like I said, it's supposed to be an adjunct or a complement, not a replacement. And I think the other thing is just ramping people up. Some people might need an on-ramp to do this, to get used to it, to understand it. There's a bit of fear with it. There's a discomfort. Are you sure about this? The numbness and the tingling, and my leg is purple, my leg is itchy, those kind of things. Like, some people just need a little more hand-holding, and I think sometimes we give up on them too quick maybe, and don't let them have, some people you can slap it on and they're good to go and give me more. Other people, they just need their hand held, right? So I think there's a piece of that. So I think in combination, it's, the load's not right, the pressure's not right, you're doing it too long, which it might be a combination of the first two, and like I said, and not adjusting loads or like I said, just using BFR for everyone for everything. And I just don't think that's the case. Anytime you have a modality or an intervention that says it can fix everything, that immediately is a red flag to me. So I'm just making sure you're on point with truly why you're using it, and will traditional loading methods do what I need to do here? And if they do, I think you should go that route.
Definitely. And I think that's it's a common theme that I've heard, and I think the BFR space has actually been a very positive space for saying something similar, right? A lot of the practitioners that you talk to that are heavily in the space, either whether it's working for a company, working research, doing all those sorts of things, they'll still say the same thing of like, at the end of the day, if they can tolerate heavier loads or higher loads, I would prefer that, because we know that there's going to be potentially better adaptations that occur that way. And so that's awesome. And that's
frankly, if I can interject, that's just one example. I think I've said from the jump on this, I'm not a huge fan of this for like the rotator cuff and for like especially baseball guys and like overhead athletes that are constantly doing volleyball, javelin, tennis for the cuff. It's like I always say, I've never had trouble getting the cuff strong with normal loading measures. And do you want, I'm just asking the question, do we want to be compressing the neurovascular bundles of overhead athletes who already have risks for, thoracic outlet, things like that? Never mind the fact that the studies on proximal are not that exciting. I think the studies on distal from the cuff are probably a little more they're a little more robust. So hopefully that gives you an example of, I'm not saying don't use it. I'm just saying that I would ask you to question maybe why you're using it for that particular population. And that's where, again, I think the clinical decision-making piece comes in. Is that if you're just slapping it on everybody, to me, you don't really have any rationale. You're just using a new toy,
Definitely. Dan, I couldn't agree more, and I really appreciate your time coming on. I think this has been very solid, just kind of like bullet pointed, like implementation, execution, what it does, what it doesn't, all those sorts of things. And so I think this is a very poignant kind of podcast for a lot of our listeners, and I think it'll be great for them to listen to. So if they want to connect with you, or if somebody wants to reach out and learn more, or just ask a follow-up question or something like that, what's the best place for them to do that?
Probably shoot me a note on X, Casey Rehab Guy. You can find me on LinkedIn as well, just under my name, Dan Lorenz. That'd probably be the two easiest ways. I'm not a huge social media guy, other than probably X. But I'd say if you do that, I'm usually pretty good about getting back to you. I'm not too big a deal where I won't respond. Don't worry.
Right on, Dan. Well, I really appreciate your time, and I think this will be an awesome listen for the listeners.
Excellent. Thanks a lot, Dylan. I appreciate the invitation. Have a great weekend.
Thanks. You as well.